So I'm pleased to introduce you Professor Annamaria Giraldi. She's a senior consultant in psychiatry in the sexological clinic at Psychiatric Center Copenhagen and professor in clinical sexology at the University of Copenhagen in Denmark. She's past deputy editor of the Journal of Sexual Medicine, past president of the International Society for the Study of Women's Sexual Health, and the current president of the International Society for Sexual Medicine. She has published plenty of papers, editorials, and book chapters in the field of male and female sexual medicine. Annamaria has been involved in the field of sexual medicine for many years, educating medical students, nurses, physicians, and psychologists in sexual medicine, and she is a very, very good teacher. She has been involved in basic research on male and female sexual response, clinical research on the pharmacological treatment of erectile dysfunction and female sexual desire and arousal disorders, as well as in the research on somatic disease, psychiatric problem, and sexuality. Clinically, Professor Giraldi works with men, women, and couples with sexual dysfunction and with transgender care. So enjoy her lecture. Please, Annamaria.
Thank you very much, Francesca, for a very touching introduction. And thank you, Evie and Francesca, for arranging this. It's so nice to be here, though the occasion is so sad. And I want to start with echoing all the nice thing that has been said about Ariel. And this picture is actually from March 2020, when we were at the ISSWSH meeting, which was like the last thing that happened in our societies, because when we flew home, basically the world closed down and we kept getting these messages about Ariel being sick. And I just want to echo that he was a very, very special person. He was kind, he was intelligent. I can only imagine how good his patients must have felt, but he was also, what was also said in the beginning, a person that really practiced the way we think sexual medicine should be practiced, with a multi-dimensional factorial approach to people's sexuality. So it is such a loss for the society and of course for his family, and all my thoughts goes to Marina and his children and his family. So it's really a loss for all of us that we don't have Ariel here anymore. So my talk, which it seems a little bit strange to go over and give a talk, but I think that my talk is something that I feel very passionate about. It's about management of psychopharmacology for sexual function. And I have discussed a little bit myself, what should I focus on? What I would like to focus on, that I don't have a lot of exciting news on new treatments or new ways to deal with adverse events, sexual adverse events to psychopharmacological treatment. But I think that the new thing is that we get more and more knowledge about how the brain works, what are the side effects of psychopharmacological treatment. And that's what the news are, that we know more and we need to integrate the knowledge we have in our clinical practice. And I hope that my talk will help you doing so. So when we talk about management of psychopharmacology for sexual function, I will, as I said, focus on adverse events. And I think that are four very crucial aspects. First of all, we need to identify that people get problems when we treat with psychopharmacology. We also need to have some knowledge about the drugs that we use before we can help the patients in the best way. We need to have a focus on this topic, and we need to know how to treat or what possibilities we have. If we look a little bit about the identification, we have to remember that people with severe psychiatric problems also have a sexual life. A lot of clinicians will say, oh, they're so sick, or they are so different because they have a psychiatric disease. So they probably don't have a sexual life, or they don't have a partner, but they still have a sexual life or a wish for a sexual life. We also know that psychopharmacological treatments are widely used for several conditions that might not be very severe or so severe as the very severe psychiatric diseases, but still we use a lot of psychopharmacological treatment without even recognizing or thinking about the sexual dysfunction they may cause. We also know that they may cause sexual dysfunction or problems because it's a very common side effect to psychopharmacology. And we also know that the sexual complaints or adverse events may actually cause a decreased compliance to the treatment that we give to the patients. So the next step was knowledge. And just briefly to summarize that we have so much more knowledge about how the brain works. We know now that the dopaminergic system is so important as a positive influence on sexuality. We know that it has an effect on desire, a positive effect on desire, on sexual focusing, excitement, being able to have an erection, being able to be lubricated if you're a woman. And it also has an interaction with the sympathetic and parasympathetic system. So the dopaminergic system is so important for the positive effect on sexuality. On the other hand, we also know that the serotonergic system is a little bit more complicated. It has an effect on desire, orgasm, and resolution, which is the phase after you have had your orgasm. But we have to look at the receptors. We know that if you stimulate the 5-HT1A receptor, it will enhance sexual function. But if you stimulate the HT2 and 3, it will inhibit sexual function. So here we really have to use our knowledge on what are we actually acting on when we treat people with psychopharmacology. We also know that serotonin will stimulate the release of endocannabinoids, and that will prolong the resolution phase, meaning that there will go longer time from you had sex until you actually want to have sex again. We also know that if you stimulate the 2H receptor, it might inhibit orgasm. And then we know that some serotonergic acting agents like flibanserin, which is a partial agonist for HT1A and antagonist for the 2A, might increase dopamine in the prefrontal cortex and actually have a positive effect on the sexual response. So there's so many pathways that we could think about when it comes to the brain and how we can have an influence on the sexual function. We also know that testosterone, progesterone, prolactin, and estrogen will have an effect on our sexual function, and especially testosterone and prolactin are some that are very, very important when we talk about psychopharmacology and people with psychiatric diseases. I'll come back to that later. So what sexual dysfunction are we actually discussing when we talk about someone that might be induced when we treat with psychopharmacological treatment? And it's all kinds of sexual dysfunction. It's decreased sexual desire, impaired arousal, decreased sensibility of the genitals, a variety of orgasmic problems like delayed orgasm, partial or total anorgasm, premature ejaculation, or decreased ejaculation volume. And finally, you can also have pain when you have sex. So it's a variety of different problems that our patients can experience. This is just an example of what might happen if you treat people with antipsychotic medication. And it's not because we have to go into each different drug, but you can see that it matters what drug we choose. Basically, or overall, you can say that the older drugs have more sexual side effects than the younger drugs. But you can also see that some of the younger drugs, like risperidone, still have a lot of sexual side effects. So it matters what drug we choose for our patients. It also matters if they increase prolactin. We know a lot of the sexual side effects related to antipsychotics are related to the increase in the prolactin. And the mechanism is that it will decrease dopamine, that's the effect of the drug, that will increase prolactin, that will decrease estrogen and testosterone, and that will increase the risk of sexual dysfunction. So we will have an effect on both men and women, but we know that women are at higher risk of having high prolactin than men, and they will also have other conditions that might have an impairment of the sexual function, like problems with menstruation and milk from the breasts. If we look at how we can use the pharmacological knowledge we have, this is just to illustrate that we actually know what is the affinity of different drugs for the different receptors in the brain. And here you can see both the dopaminergic receptor, the different serotonergic receptors, the alpha adrenergic receptors, and also the H receptor. So if we use the knowledge we have, we are actually able to predict a little bit what will the sexual side effects of a drug that we use actually be. And the H receptor, I'm sorry, is the histaminergic receptor, and that will cause sedation if we give a drug like that to patients, which might also impair their sexual function. So if we think about the drugs we give, we can, from the profile of the drug, predict a little bit how will the effect be on their sexual function. Of course, we have to use the right drug for the condition we treat, but we might take into consideration also what will the sexual side effects be if we want to help the patient in the best way. When it comes to antidepressants, we have quite a lot of knowledge now about how different antidepressants will have an influence on sexual function. And as you can see here, the ones with the very high risk of sexual dysfunction are especially the serotonergic reuptake inhibitors. Also, the SNRIs, serotonergic reuptake inhibitors, have a high level of sexual dysfunction. Other types of antidepressants might have a middle risk or a lower risk. So again, if we have this knowledge, we can think about it when we give a drug, if possible, to choose a drug with less sexual side effects than high risk of side effects. We know that especially the antidepressants with pure serotonergic effect are the ones that have the worst sexual side effects. But we also have emerging evidence or knowledge about that not all patients are the same. So there might be differences in the serotonin transporter genes that might have an effect on whether a person will develop sexual side effects to a SSRI treatment or not. So this is something we have to look into in the future to see, can we actually distinguish people that are at high risk of having a sexual side effects or people that are not in a high risk? And this is something we need to do more research on. A new entity or a new aspect of treating with SSRI is what is called post-SSRI sexual dysfunction. And listening to Sue's presentation, I think we can compare it a little bit with the PGAD discussion. This is something that has come up as case studies. People have been describing that even though they discontinued their SSRI treatment, maybe weeks, months, or even years after, they still have sexual side effects that they cannot get rid of. We don't have a lot of large studies, but we are gathering more and more knowledge about this. So what is a post-SSRI sexual dysfunction? The patients will complain about genital anesthesia, decreased desire, erectile dysfunction, orgasmic problems, premature ejaculation, lubrication problems, or nipple insensitivity. So it's basically the same sexual problems as they might have had when they were in active treatment. We don't know why they developed this. There have been many theories about it. Is it an epigenetic gene expression? Is there an impact on the cytochrome system? Is there a serotonin-induced neurotoxicity? Is there a downregulation of the HT1A receptor due to the high level of serotonin? Or are there changes in hormones, other neurotransmitters like dopamine in both the central and peripheral changes? So I think that in the future, I hope we will know more about this and be able to describe it a little bit more and maybe identify the persons that are in high risk of developing post-SSRI sexual dysfunction. So my other focus was that we need to have a focus on the sexual adverse events to psychopharmacological treatment. And I think we as healthcare professionals really need to bring it up and talk to the patients because the patients will not do it. And this is illustrated very well in a study. It's an old study, but I really like it, where more than 300 people participated in a trial for an SSRI. And they were asked if they had any adverse events to the treatment, and only 14% said they had sexual adverse events. Then they went out of the office and received a document where they could tick off which adverse events they had experienced, and that included sexual side effects. And then 60% said they had experience sexual side effects. So we need to ask directly about sexual side effects because our patients would not tell us because they might fear they are strange or it's embarrassing to talk about sexual side effects. So how can we manage this? And I think it would have been nice to come and say, wow, we really have a good way to manage this. We can wait for tolerance. About 10 to 20% of people will be more tolerant to the sexual side effects, and still is not a very good advice because the rest, the 90 to 80% of the people will still have the sexual side effects. So I think we need to think about dose reduction. We know that the sexual side effects are related to the dose you give. You might change drug, and I really recommend, as I explained, thinking about the drug profile. You might change the dosing time. Sometimes it's easier to, if you have inhibited orgasm, if you take the drug and then you have the peak in the concentration in your blood exactly at bedtime when you want to have sex, you might just change the time of dosing. People might take drug holidays. If you have a short half-time of the drug, maybe if you skip a day, then it will be quickly a little bit out of the blood, and then you will have less side effects. And then we can, of course, treat the sexual dysfunction as we normally treat sexual dysfunctions with PD-5 inhibitors or with hormonal treatment if we think that will be beneficial for the patient. Then we have what I call antidote treatment. I'll get back to that in the next slide. And then, of course, we need to inform the patient. We need to educate the patient. We need to give them basic sexology treatment. We need to focus with them that sex might not have to include penetration. Maybe you don't have to have an orgasm. We need to instruct them in sensate focus, change of intimacy, change of sexual behavior, all the things that we usually also teach other patients with sexual problems. If we look a little bit of what I call the antidote, there are several drugs that will have an effect on the central mechanism of the brain, like bupropion and buspropion, which will have an effect on the 5H1A receptor or dopamine and norepinephrine. We have several agents, as you can see, that will have other effects on the serotonergic or dopaminergic system. But what I think is very promising also now in the future is now we have flibanserin and bremelanotide, which was developed for women with low desire, which might go and reverse a little bit the side effects. We know that if you give flibanserin to women that are on SSRIs, it might still be beneficial for and helping them with their sexual problems. We don't have any data on bremelanotide yet, and still we can use hormonal treatment. So I think that my take-home message is that we really need to focus on the possible side effects when we treat people with psychopharmacological treatment. And if you are interested, I just want to advertise a little bit a book that I co-authored and co-edited on psychiatry and sexual medicine, because it is a field that is growing. We have more and more focus on how important it is to include psychiatry in our field of sexual medicine. So thank you for being here, and thank you for having me here in this very remarkable event. Thank you, Francesca, and thank you, Evie, and thank you to the panel for so many really, really great talks. I think it's such a wonderful program. Thank you.